Hey, I'm Stephanie Brown. I'm a real estate broker, mom, wife, and a serial entrepreneur. Welcome to It's More of a Guideline, a podcast where we talk about navigating the world of entrepreneurship, relationships, health and fitness, and whatever else may come up. It's honest, raw, and authentic. Hi, Julia. How are you?
Hey, Stephanie. Good. Thanks for having me.
You.
Yeah, you too.
Yeah. So welcome to the podcast. It officially has a name this time. Last time it didn't have a name. It's called It's More of a Guideline.
Okay.
So that's the name of the podcast. It's official.
The guideline?
It's more of a guideline.
I love that.
Yeah. Well, why don't you just give us a little rundown of like a 20-second bio of who you are, and then we can jump into it and get on topic.
Yeah, sure. So I'm Julia Montgomery. I specialize in hormone replacement. I'm a board-certified family nurse practitioner. So I own Venture Wellness, which is located in Midlothian, Virginia, where I specialize in hormone replacement, medical weight loss. I call myself functional light, meaning, I do have a functional approach in terms of interpreting lab values and treating patients, but without throwing like 100 supplements at you, because that's really not realistic. So really finding a realistic approach to treating your underlying cause and symptoms.
Yeah, cool.
Yeah.
Cool. Well, the reason that I asked you to be on today, I feel like in my algorithm in life right now is all of this talk about hormone replacement therapy and perimenopause and menopause. And, I have friends that are on the spectrum everywhere of that. And a lot of my friends are a decade younger too. So, I'm witnessing some of them having these experiences and symptoms that are not really, they're not tying to perimenopause just yet, right? Because they're 40 or 41 and they're feeling anxious or brain fog or, all of these things. And having been now 10 years later down this road, I'm like, oh, I can pinpoint like probably what that is, right?
Yeah.
But I feel like it's such a weird topic. People don't really talk about it until you get into it, and then you start having to like do all this research for yourself. And so in doing that, I've also noticed, or in having these conversations with women and friends and colleagues, that women are having a hard time getting hormone replacement therapy.
Yeah.
And I know you and I've talked about that a little bit, but why do you think that is? What's happening in like OBGYN world? And, that's where most of these women I feel like are finding their care providers. So give us a little insight on what's happening there.
Yeah, so a little background, women's perimenopausal symptoms and all of that really weren't studied until at least the 1990s. That's when women were required to be participants in research subjects. So a lot of research was done on men initially, and there really wasn't a lot of information on women going through that transition. We knew what menopause is. We know it's a biological process, but it's not something women need to suffer through. And really, now women are seeking answers. We've got social media, we've got influencers. There's so much more well-informed now, and they're advocating for themselves. So the landscape itself is changing as far as healthcare, and there are providers that are willing to meet them where they are. But, a traditional insurance model, the physicians that are practicing right now really weren't trained in hormone replacement, whether it's GYN or primary care. There's no guidelines. And there's actually a study that came out in 2002, which was the Women's Health Initiative, that was, looking back now, it involved synthetic hormones in a much older female population. And it did show some lots of side effects of hormone replacement. But since then, recent research indicates that their bioidentical hormone replacement can actually be safe and beneficial for many women. But the provider training has not caught up with that.
I'm seeing like women that I'm talking to, or they're going to their standard OBGYN versus someone who's trained in hormone replacement therapy, and they're being put on birth control pills, right, as their hormone replacement therapy, which is not hormone replacement therapy, right?
It's not bioidentical. So, our healthcare system really focuses on treating disease rather than optimizing wellness. It's really hard to prevent issues in a traditional healthcare model. So the difference between bioidentical and synthetic hormones, I like to say it this way. So synthetic hormones fit the lock, the key fits the lock, but doesn't turn the lock, where bioidentical fits the keyhole and turns the lock. So it is your body is able to absorb it better and get better levels that way. Now, unfortunately, there are very limited FDA approved bioidentical options for women, especially testosterone in the US. Australia does have some testosterone replacement for women, but there's no studies, and pharmaceutical companies aren't putting in the research funds
Right.
to fund FDA approved options. So from a prescriber standpoint, a lot of them shy away for medical legal reasons too from prescribing that.
Wow.
Yeah.
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 So when you are, let's walk through like the steps of someone comes to you. We'll talk about women first because that's where that's where I like to start. When they come to you, we're getting blood work, right? Okay. And then you're treating off the blood work or their symptoms or both?
Yeah, great question. So really the symptoms drive the care because a lot of these symptoms are nonspecific, which is where, a traditional healthcare visit with a GYN or a primary care provider, you're limited to like 10 minutes. You're in and out.
Right.
We
because they
really
have to see how many patients a day.
They have to
right?
see 20 plus patients a day and to get limited reimbursement. But really, it does take time to dive into those symptoms because a lot of them are nonspecific. Fatigue, bloat, weight gain, brain fog. Those can be tied to any
Sure.
cause,
Yeah.
not just hormones. So, when I see a patient, I do go over lifestyle. Do they have difficulty sleeping? Well, why? Sometimes hormones do drive insomnia. That low progesterone, you'll wake up, you'll have a hard time going to sleep, or
Right.
high cortisol, you'll be waking up in the middle of the night from stress. So we take time to dive into lifestyle factors and symptoms and labs. So the labs are great for trending and supporting therapy, but really the symptoms drive the care.
Okay.
A single lab value is not going to show me the full picture. It's really the ratio between those lab values, especially for women, because our hormones are much more complex. We have, much larger amounts of the progesterone and estrogen. Men do make very small amounts,
Yeah.
but for them, it's a little more streamlined. It's testosterone, but women's hormone replacement is a little bit more nuanced. And looking at that ratio between progesterone and estrogen does help drive that balance rather than just looking at your estrogen is this particular number. That doesn't tell me as much.
Right. And we're still producing estrogen through perimenopause, right?
So yeah, this is where perimenopause is wild. It's a wild ride, and it actually starts in women's late 30s.
Yeah.
That's when those hormone shifts start, especially, we're having children later in life
Right.
too. So, women might have their second, third baby, and then they notice their hormones are never the same after. Well, is it the chicken or the egg, right? You're already entering like your mid to late 30s, and you're seeing those hormone shifts. Now, during perimenopause, it's not just a steady decline in hormone production. It's actually a spike and a drop and a spike and a drop, which is really what causes those wild symptoms of perimenopause. Now, as you head towards menopause, there is a decline in hormone production, and that's really where we ramp up hormone replacement. So during early perimenopause, I usually support women with progesterone. And, I do love an IUD for a perimenopausal woman. If they're having heavier bleeding, some symptoms of lower progesterone, sometimes if they tolerate an IUD, that does help. But the IUD, especially like a Mirena, doesn't have estrogen in it.
Okay.
So it's not true BHRT, but it is some hormone support to bridge them through as they continue to shift towards menopause.
Okay, gotcha.
Yeah.
And then, so how do you, when you're looking at those numbers then, and then you're looking at symptoms, are you just trying to figure out, like, based on the symptoms, what level, or where do you start? Where does someone start? Like if someone comes in and they're having these low levels and blood work and then some of the symptoms.
Yeah, so it depends on the symptoms. I do have women that come to me and let's say they're in their mid 40s, they have low libido, they have brain fog, they have they're starting to get more fat deposits around their belly, the weight's starting to redistribute.
Right.
I'm going to get a full panel. I'm also going to ask them a full symptom questionnaire. And I don't just screen for perimenopausal symptoms. I also screen for symptoms of thyroid function and adrenal balance. And, in our fast-paced lives, like we are not made to live in this fast-paced world where it's constant contact, nonstop, these high-achieving... Fight or flight all the time, these high-achieving women. And we also internalize our stress, and that turns out in insomnia, constipation, GI symptoms. So really vetting out the full picture. And then I really like to hit, like, what is the most bang for your effort and time initially to get to your goal. And it's really a layered approach. So we'll start, we look at thyroid also. Is thyroid optimized? Are sex hormones optimized? And we layer that on because hormones are slow. If we start somebody on hormone replacement, they might not see full benefit for about 12 weeks.
Wow.
Puberty takes years, and so does hormone replacement and the transition into menopause.
Yeah, so it's like a marathon.
It is a marathon.
Not a sprint.
It is not a sprint. It is not a quick fix.
Right.
Now, it is much quicker than waiting years and years until you're postmenopausal, which, some women don't have symptoms, but many, many women do, and they suffer.
Yeah. I feel like having social media or TikTok, especially like women going on TikTok and really sharing experiences, are bringing this to light in a way because, at 50, it's just been in the last 2 years that I've started to get into this and really research and, it's just so I've been, an advocate for women's health and maternal health and this being so far out of the range, maybe just because of where I was in life at the time, but now it just seems everywhere.
Yeah.
It seems like it's really people are really starting to dig in and figure out ways for treatment.
Yeah, and I think women are demanding better care.
Yeah.
We're so much more informed now, and we're asking providers to treat us. And unfortunately, the healthcare system hasn't caught up
So
yet.
how does someone who doesn't have anything other than a PCP or a primary care and then an OBGYN, and they want someone who specializes in hormone replacement therapy, what's the step?
Yeah, so there are the American Menopause Society. You can find a provider that is well versed in menopause. There are other training bodies where you can find a provider, but really it's important to advocate for yourself. If you're feeling off, if you're feeling not right as far as your symptoms and you're being dismissed, do dig into the literature and consider seeking out a healthcare provider that does specialize in hormone replacement therapy.
It seems like there's a lot of online help right now. Is that something that how do you feel about that?
Yeah, so the online help...
the middies and all those...
Yeah, it really depends the level of touch points and care that you need. When as a prescriber, I like to watch my patients very closely because the right therapy has to work for you. You have to have minimal side effects and you have to have so much education. I love to empower my patients with the knowledge so that they know what to watch out for, what are the side effects, how to, when to contact me, how to advocate for yourself if something doesn't seem right, or if you feel like you need to move up, move down in your dose, especially in perimenopause because things are shifting.
Right.
When we enter menopause, things are a little bit more steady. We don't titrate as much, but a lot of the online type of care models, you don't form that same relationship because really this is a journey that we're on together, especially starting out early. Symptoms of perimenopause start about a decade prior to menopause.
And can we just clarify really what perimenopause is and menopause?
Yeah,
and postmenopause?
Great question. So perimenopause is really the beginning of the shift. So the ovaries are responsible for the production of the majority of our sex hormones. We do make some in the adrenal glands as well and in other parts of our body. But, if it's surgically removed, you're entering menopause already, right? If
So
they
we're
remove
talking
the ovaries.
about someone who's not had a hysterectomy.
Somebody who's not had a complete hysterectomy. So if they remove the uterus, left the ovaries, a lot of times you're not in menopause yet. Sometimes if they've removed one ovary, we do see some hormone dysfunction. And again, this is where we get into that optimal health versus being sick on the lab values.
Individualized help, right?
Very individualized, very symptom driven. A lot of these average lab values were based on an average population 50 plus years ago. And we know that it's outdated and we know that it's very individualized too. Some women feel great with the testosterone of total testosterone of 50, for example, and other women have symptoms of high testosterone at that level. So it is very individual to your biological makeup, your genetics, and lifestyle.
And women today are so different than women 50 years ago. I mean, gosh, just like metabolic health alone and the way we're taking care of ourselves.
That's a great point. And it's, I see this especially in men, but, we are having shifts in hormone levels and, pesticides, microplastic, endocrine disruptors in...
Oh, that's another thing I wanted to ask you about hormone disruptors, like in your household. too,
Yeah.
if you have any.
So I like refuse to microwave anything in plastic.
Okay.
I like
Okay.
freaked out on my husband the other day because he heated up my daughter's mac and cheese in a plastic Tupperware container.
Yeah.
And I was like, no. My mom had breast cancer at the age of 35. So I've
Wow.
always been really
Yeah, that's
like
young.
cognizant of
Sure.
hormone disruptors. You know, no genetic link, genetic testing's negative, but it's always kind of been on the forefront of my mind. So,
Yeah.
which really caused me to dive in and really learn and become an expert in this field. But, you know, try to purchase products that are cleaner. I mean, you know, they're finding microplastics like in our brain and in our lungs now. So there's only so much we can do to really avoid
Yeah.
the environmental exposure, you know, buying organic when we can, avoiding, you know, eating cleaner.
Right.
But again, we have to be realistic.
Avoiding dyes and fragrances when you can.
Yeah,
in the
yeah,
household.
exactly.
Air fresheners,
Those
fabric
plugins,
softeners,
yeah,
all that
stick to
stuff.
essential oils,
Yeah.
you know, flower, like real flowers and things like that for scents. Yeah, do what you can, but it's got to be realistic. We can't live in a bubble,
Yeah.
unfortunately.
Even in teenage boys too. Like I think about that. You know, I have a son who's getting ready to turn 16,
Yeah.
and you know the body wash and the cologne and all that stuff.
Yeah, I mean, I had a male patient who's in his late 20s, works in a paper mill. Came in with really low testosterone. He's a shift worker, works night shift, so lifestyle does play a factor into it, but not 100%. It's a, you know, multitude of things that kind of impact our, you know, how our body functions in that feedback loop of hormone production. Yeah.
Well, let's talk about men for a second, because before we
Yeah.
started recording, we chatted about it for a moment, and you were sharing with me that you know men have a different outlook in coming to you for care, right? Because they're either embarrassed or they don't want to. And every man past a certain age has low testosterone, right?
Yeah, especially men over 40.
Yeah.
And again, these lab values, LabCorp actually shifted their lab ranges a few years ago because they've seen an average decline. So they just shifted those ranges down.
Wow.
And like, just because, you know, it's an average and it's normal of our population, is our population normal? You know,
Right.
are these levels optimal? Because I do have men that come in and they're tired, they're unmotivated. Some have erectile dysfunction, some don't. And the one that do, they are shy. Like that is something they don't want to seek
that's hard
help
to
about.
share with someone, right?
Very
Yeah.
hard to share, whether it's a male or a female provider. That is something that is very difficult. So, you know, part of my clinic and the environment we have is very comfortable. You know, more of a home-like setting, so that they are open to sharing, because the more I know, the more I'm able to help them
Yeah,
as well.
right.
So yeah, men that you know, don't seek out the help, they struggle with it until, you know, the symptoms really add up and they develop high blood pressure and diabetes and all of these other consequences of having poor metabolic and hormone dysfunction. And I actually had a patient recently, and what prompted him to come to me was his primary care provider was going to put him on a blood pressure medication.
Okay. Yeah. Because that's typically what they do, right?
Traditional,
Yeah.
you're overweight, here's your blood pressure medication. You know, he's telling his provider he's tired. Pretty generic symptoms that we all probably complain to our primary care doctors about. But it was getting put on the blood pressure medication that was kind of like the aha moment of, okay, I need to get my life straight.
Yeah.
So, you know, I knew him pretty closely, now I do a full lab panel on all my patients, men or women. So I do look at full metabolic health, thyroid health, as well as hormones, because they do all play together, and these symptoms are very nonspecific. So he did have some insulin resistance, but he had low testosterone. It was like 200. It was markedly
Right.
low. Well, if I told him to go exercise and lose weight, he's not going to be able to with a testosterone level that low.
He's not going to feel motivated.
No, he's not going to get
not gonna have
motivated.
strength. Yeah.
Yeah. So started him a testosterone replacement. He lost 40 pounds as a whole new person, looking so good.
That's
So
awesome.
that's where it's really life changing. You
Yeah.
know, they're more motivated. I've had men come off their antidepressants or decrease the dose of their antidepressants after
Yeah.
starting testosterone replacement. Yeah. And I think, you know, there's a stigma with
Is
men.
that because they're being misdiagnosed?
Often, yeah, because no provider is going to check a testosterone level when
Right.
somebody's complaining of low motivation,
Yeah,
difficulty
and tired,
sleeping,
yeah.
Because we just weren't trained to think like that in our training or in school. I wasn't when I was training. It was after, you know, I was working in urgent care, and I just keep seeing these people coming in with complaints. I'm like, well, what is causing this?
Yeah.
You know,
Why are
I
we
had-
trading
yeah,
symptoms here instead?
Yeah, older women coming in with frequent UTIs. Well, that's because the tissue there, you know, does become drier, and you get frequent UTIs as you get older. Well, that's not normal.
I saw this just yesterday, Halle Berry. Have you seen this clip of her on the Drew Barrymore show?
Oh no, I saw her in her dress that she wore like 20 years ago.
Oh,
She wore it
okay.
now. That looked
Well,
good.
she talks about she was misdiagnosed at her doctor told her that she had a really severe case of herpes, and it was just vaginal dryness, but she wasn't.
Oh wow.
Yeah.
And she probably has access to the best care.
Right,
Yeah.
yeah. So now she's on like hormone replacement therapy.
Yeah.
And she's, yeah.
Yeah, feeling much
Yeah.
better. And that is something, you know,
Wild.
there are risks to hormone replacement if you are high risk. So for example, women with a history of breast cancer, things like that. So you do have to go to a provider that is well versed in hormone
So
replacement.
it's maybe not for everyone.
Yeah, not for everyone, but when it comes to symptoms of vaginal dryness and kind of those less full body symptoms, even women that are high risk have options. So I don't want any woman out there to think, oh, you know, I have this history, I know I can't have hormone replacement. We do have options to prevent a lot of the consequences
Yeah.
as well.
Let's talk about GLP-1s.
Yeah.
And we talked a little bit about the microdosing, and when GLP-1s first became like so popular a couple years ago, everyone I knew was getting on one, and I was like, oh my gosh, like what's happening? Like what's going to happen in 10 years? And you know, a little bit concerned, but now it seems like the more that I've read and researched and learned, like some of these GLP-1s, especially microdosing, are just having incredible effects on people.
Yeah, absolutely. I love microdosing GLP-1s. You've got to be the right person. So if you're somebody who's already very active, you know, you're doing strength training, you have maybe 5 to 10 pounds to lose, and you have that abdominal fat. That's really hard to get off. Even with HRT, you know, we do have that redistribution of fat, even after starting with testosterone replacement for women. And microdosing GLP-1s is a great way to kind of stay lean that way. There's a lot of anti-inflammatory benefits to it. Now, the drug class itself, GLPs have been around for many, many years, and they were originally used as a daily injection for diabetes. Now, with these newer peptides that are used primarily for weight loss, we don't have long-term studies on these higher doses of the GLP-1s, but they are absolutely life-changing for people. So with microdosing, you know, it might be that you just do a small, you know, tiny dose every couple weeks, just to kind of have that little layer in the background to help with metabolic function, and optimizing your body fat percentage.
And is there are you seeing like a peptide that people are pairing with those also? It's like, let's take someone who's active, who's you know, trying to cut down on a little extra body fat, and who wants to pair it with like a microdose GLP-1.
Yeah, so again, I like to make sure everything's within range before microdosing, because I want to optimize everything before we kind of layer another therapy on board, so we can add in microdosing. Some people do have a lot of benefit with human growth hormone, for example.
Okay.
That's another peptide that's great for sleep, decreasing abdominal fat, increasing muscle mass. It does need to be monitored with somebody who's well versed in peptides. And
are people scared of that when you say those words like hormone growth?
Human growth hormone. I think the people that have done their research are very, very excited and open to it. The people that don't have as much research, again, I like to empower them with all the information, because the benefits do need to outweigh the costs, the consequences, the side effects. Because
it can be expensive, right?
Yes,
There's
they are.
Most care providers who specialize in hormone replacement therapy don't take insurance.
Yeah,
right?
They don't take insurance, and a lot of times these medications aren't offered through retail pharmacies, so they have to be compounded, which means you can't use your medical drug coverage either. So it is out of pocket. Now, I know a lot of providers, including myself, do accept HSA plans. So if you have an HSA benefit, it's a great way to utilize that. But it is an investment in yourself and your longevity. It is really what it comes down to, and preventing, you know, health consequences later on. So maintaining muscle mass as you get older, because we lose a lot of our muscle mass after the age of 30. So staying active, and you know, there are other peptides that we can use for joint pain. You know, so you're not taking, you know, 4 ibuprofens every few hours every day. So really it's about regenerative medicine and longevity.
And what are your thoughts on maintaining that muscle mass, like as you get older, and as far as like fighting disease and staying stronger longer longevity of life.
Yeah, I think strength training is the number one thing men and women can do for themselves to stay active and
Yeah.
strong as they age. Having that muscle mass around your bones, your ligaments does prevent injury as you get older as well. Helps, maintain metabolism, and
Yeah.
all around.
Why do you think so many women are still in like
Cardio mode.
Yeah.
I know. I tell my women all the time, like, I mean, you can do some HIIT here and there, but really
Right,
start
if
with
you need to
strength
get
training.
yeah.
I think a lot of women, and I still hear my patients will say this too. They're like, "Oh, am I going to get like jacked? Or I don't want these big
Right.
muscles."
I
I'm like,
wish.
"Yeah, like
Yeah.
you're not gonna. You don't have the testosterone levels of a
I've been
man."
lifting weights for 30 years trying to be jacked.
Yeah.
Like literally.
Yeah, and I think, there's being, putting on muscle bulk and then there's leaning out and having that increased muscle definition. So that's going to be that body fat percentage.
Yeah.
And that's where GLP-1s dosed appropriately at the lowest effective dose can be really helpful because they'll lean out, but you're
What is a low dose?
So the starting dose based on the FDA approved studies is 2.5 milligrams for tirzepatide or 0.25 milligrams for semaglutide. I do prefer tirzepatide, which is Mounjaro, Zepbound as the brand names, but those are not available in a microdose.
And that is not a GLP-1, right? That's a GLP-2, or is that?
So it has it covers two peptides
Okay.
instead of semaglutide just covers
Okay,
one.
got
So
it.
it actually works down two different pathways. It has less side effects and it's better tolerated. It's a little bit more potent. It's also easier to dose just kind of based on the concentrations available. So people, if they're drawing up their own injection, it's a little less confusing for patients as far as dosing. So let's use tirzepatide as an example. So starting dose for somebody starting a GLP-1 for weight loss, for diabetes is 2.5 milligrams. When I microdose somebody, it's maybe 1.5 milligrams, maybe 1 milligram.
Okay.
And it's not every 7 days. It's, every other week, or you really have to be, practice some intuitive eating, some intuition to make sure you're not cutting too many calories. It's not blunting your hunger response too much, but enough to be in a slight calorie deficit so that you're able to still put on lean muscle mass while maintaining optimal metabolic function. Because really, when I look at it, that's your metabolic function enhancer. It is really how I see it. It helps with inflammation as well.
Have you heard of people who are saying they're like not having the desire to drink coffee and drink
Yeah.
alcohol and gamble and smoke cigarettes and all these other things?
Yeah, I get
that?
coffee and alcohol a lot.
Yeah.
So
Is that a taste thing or is that a brain?
It does affect the
knows?
brain.
Okay.
There is a warning on both of the manufacturer side effect profiles that can increase risk of suicide and depression. I'm not not sure exactly which pathway dopamine it works down, but it does affect the brain, not just the gut. So some people can have increased symptoms of depression, especially with semaglutide.
Okay.
Yeah.
I've seen some opposite too, though. Like some people saying that they're
It's
not.
freeing. It's
Yeah.
absolutely freeing for so many people.
Yeah.
So small percentage of the population might have that higher
Gotcha.
risk.
So they have to
but
put that in
generally, most people, they're like, I had 2 patients tell me this week, they're like, is this what normal people feel like?
Oh my gosh.
Like, I'm not always thinking about my next meal or,
Yeah.
what I'm going to snack on. It's so freeing. And I actually
Yeah.
have more mental bandwidth to focus on, work, kids, meal planning. So I actually, for my weight loss patients, I do use it as a tool to work on those core behaviors to fuel long-term weight loss.
So do you think there is a link between that to like helping people with ADHD?
I think so, absolutely. Especially my high achieving women that
Yeah.
internalize everything,
Type A.
that have a million tabs open
Right.
and have a hard time focusing. It does really help. I do sometimes. I will add a little non-stimulant ADHD medication for my weight loss women. That
What's that like? What's a?
I
example?
love Strattera.
Okay.
A lot of people do well with it. It's not a stimulant. I don't love putting women on stimulants. Again, that's that cortisol. They're already in burnout mode.
Yeah.
I don't want to add a stimulant long term, greater than 3 months or so. Unless we're able to practice some lifestyle change, meditation, exercise, of course, is a great tool
Right.
for ADHD, for health in general.
Yeah. Where does metformin fit in?
Yeah, so metformin is interesting. There are a lot of studies and there's a lot of biohacking where people love to use metformin for inflammation, longevity, insulin resistance. I think if you're taking a GLP-1, I generally tell you, you can stop your metformin while you're in the GLP-1. If you're somebody that already had some insulin resistance, to start with, and you're coming off the GLP-1, sometimes we'll watch the numbers and put the metformin back on. There is a supplement called berberine. That is similar in function to metformin, that's non-prescription. That also has some biohacking longevity benefits. It also has some antimicrobial properties as well. So
okay.
it is important to not take long term because you want to preserve that
Right.
good gut bacteria.
Some people have some gut issues.
Yeah. So it is something that, relatively low side effect medication. It does impact B12 absorption.
Okay.
Metformin does. So again, close monitoring, making sure B12 levels are optimal, or using some supplementation is also important.
Yeah. Okay, cool. Yeah. Let me check my little note section here. Testosterone. Minoxidil.
Oh, for hair regrowth.
Yeah. So tell me a little bit about that. That's something I've seen around the same, like the perimenopause.
Yeah. So with hormone changes, and we're seeing a lot of HRT and medical weight loss in combination for a lot of people.
Right.
They're on the GLP-1, they're doing hormone replacement. So they're cutting calories and drastic weight loss will always cause hair thinning. That's why I watch a lot of my patients very closely. I usually don't let them lose more than 2 pounds per week because we want to preserve micronutrients and nutrition.
Which happens on a GLP-1 or not on a GLP-1 right? Like if you're cutting calories.
Yes, either any drastic weight loss. So it's not really the medication that's causing that. It's the rapid weight loss. Any major stress. A lot of times around this age, women are also sandwiched. They're taking care of children. They're taking care of aging parents.
Yeah.
They're in their prime at work. So stress will cause hair thinning. Hormones also will as well. Now in women, there is some genetic hair loss, like women's female pattern baldness. That minoxidil will not help.
Okay.
However, if it's anything that's related to like high testosterone, like high androgens, PCOS for women, they'll have a lot of thinning around the hair crown, thyroid function, again, micronutrient deficiencies, low estrogen. Correcting those underlying deficiencies is important, but while we're correcting and while we're optimizing, doing some minoxidil with finasteride, also they block a hormone called DHT, which promotes hair growth, can help. I usually do recommend, some sort of supplement with high biotin, all the micronutrients to support the hair growth as well, and protein intake. So, protein intake is typically the hardest for most people. So that focused protein, and it doesn't have to be 150 grams of protein. I do feel like if we're doing protein calculations, we often overestimate our daily protein needs unless we're very highly active athletes. So, for an average person, a minimum of 80 grams of protein is still a stretch. So trying to hit, half a milligram of protein, half a gram of protein per body weight is ideal.
Okay. And so what do you think the average protein intake is of a woman in her 40s and 50s?
Yeah, I would say 40 milligrams, probably low. A lot of women skip breakfast. We go all day without eating, and then we're like, oh my God, I'm so hungry in the evening. And what do we reach for? Like the pretzels and
carbohydrates.
The carbs. So
when are they gonna make a protein like a mac and cheese? Just like I know we can do it, or pizza. Or
protein pizza.
I mean, there is protein pizza, but it's just not that good.
It's not that good. Yeah. So and a lot of these foods are still very processed. They're full, the fillers.
I eat a lot of that stuff too, but
so we can only do so much. I mean, protein drinks are great, but we digest those really fast too because they're liquid, so they don't keep us full. Protein keeps us fuller longer too. So going all day without eating, you think, oh, I didn't eat all day, I'm still gaining weight, but in reality, you kind of you get your whole full calorie intake at the end of the day. Or you're
so late.
And, if you're great all week and then you binge on the weekends, you've kind of washed out your full week's progress too. So it's not just day to day. It's also like, we can zoom out and look at your full week's intake and see, did we ruin it over the weekend? Did we compensate, and looking at our full intake? So I do recommend, tracking like via one of like MyFitnessPal, whatever app you prefer, for 1 week. Track everything you put into your mouth, zoom out and look.
Yeah.
Because, what am I taking in?
I mean, I'm very careful about what I eat, but I also, when I track,
Yeah.
I'm like, oh gosh, I didn't know I was eating that
Yeah.
much fat, or I didn't know I was eating that many carbohydrates, or, it is really, really great tool to track.
Yeah.
What are your thoughts on intermittent fasting around perimenopause and menopause?
Yeah, great question. I like intermittent fasting, but it's got to be for the right person. So if you're one of those people that's like, I didn't eat all day, and then you're having a hard time, controlling that intake during your eating window, it's probably not for you. My favorite way to do intermittent fasting is just stop eating, 4 hours before bed.
Yeah.
So let's say you eat dinner, we eat dinner, my family, pretty early. We eat at like 5:30,
Yeah.
6. 6 is late for us.
Right.
And after that, we really don't eat
Yeah.
until the next day. So if you're waking up early, that's a
Same.
fasting window.
Yeah.
So you're already
It's a
naturally.
pretty big fasting window too.
Yeah. So you're naturally intermittently fasting without starving yourself all day when you need that energy to fuel you. A lot of times, even if we're not, especially on a GLP-1, we might not feel hunger in our belly. Like we don't feel our stomach grumbling because the way the medication works, but we might feel tired, brain fog, irritable.
And
And
a little
it's
snack.
yeah, you're hangry.
Yeah.
It's because you needed some food. Usually when my patients were, I ask them pretty upfront, do you feel that? They're like, oh yeah, it was time to eat.
Right.
So sometimes like even scheduling an alarm for somebody who, if you're really busy and you're go all day and you forget to eat, scheduling an alarm, every 3 hours or so to have a small snack. And when I say small, I mean the size of your palm. Our portion sizes are way overblown too.
So some protein.
Yeah, some protein, don't be afraid of carbs. Complex carbs are great. I do treat fruits as a carb. They're high glycemic. So you can have that with some, some slow release, peanut butter or an egg or a cheese to fuel you through your day.
Okay.
Yeah.
All right. And then I had one more on here. Okay. So when you are prescribing like a testosterone or an estrogen, or are you doing a gel, a patch, an injection?
Oh, yeah.
What's your...
So this is very provider preference.
Okay.
So for women, progesterone I prefer as a capsule, not a cream, because to put on a cream every day is a pain, and we're all go.
Yeah.
And that's not as convenient. Estrogen I love in a patch for women, but if you're swimming often, if you're a hot tub user, it's probably not going to be the best method of delivery. So there are other options. So the oral options for low risk women, and then there are vaginal inserts that we can use or a cream. Testosterone for men or women, I do prefer injections. For women, it's a lot. It's not. Women aren't frequently prescribed injections. Usually it's pellets or creams.
I've heard that the pellets are hard to, once they're in, right?
They're
So you
in, they're
can't
in.
adjust
Exactly. And really what we see with pellets, I've done pellet training courses myself and decided not to offer them because what we see, especially for men, but also women, is that initial dose, that initial pellet insertion that you get a high burst of hormones. So you get this high level and then you never really reach that peak again once you get repelleted because your body gets used to it, and then some people just don't feel as great again. And I do have a lot of women that come to me that have been pelleted by other providers and their testosterone levels are through the roof and they're starting to have, adverse effects of high testosterone that women shouldn't have. So increased hair growth, deepening of their voice. Once your voice deepens, it does not return. So it is something that pretty conservative with dosing women with testosterone. I mean, it's 1/20th of a dose of a man. It's an injection, tiny injection under the skin. So just like a GLP-1 shot, twice a week. Generally, that keeps our levels pretty even. For women that are like, I don't want to do an injection, it would be a cream. With creams, you have to be careful not to transfer it to children, pets.
On the toilet seat.
Exactly. Anywhere. Your partner also. So, it depends on your lifestyle. So my dosing, it's got to fit your life.
Right.
I do shy away from pellets. Pellets might be a good option for somebody that's been on HRT for a long time. We kind of already know their dose. We can translate that over to pellets, but they are invasive. There is risk of extraction, so they can come out on their own. So it's a little bit of more traumatic.
Where are they placed? Like in the arm?
So in the hip.
Oh, okay.
Generally, that's where they're placed, like the lower hip or the buttocks.
Do you see them and feel them?
Sometimes you can. It depends on the patient's body size.
Sure.
But it is a little bit more traumatic. Some people really love it, especially people that travel often or like people that work on like oil rigs, right? And they can't bring all their stuff with them. That might be a good option for somebody.
Okay.
But generally, injections are my preferred way for testosterone replacement specifically.
Okay, cool.
Yeah.
So tell us how then, and we'll wrap up because I think we're probably approaching the 30 minutes. If someone is local in our area in Richmond and wants to reach out to you, like what's the best way to contact you? What's the best way to schedule and get going?
Yeah, absolutely. So you can find our website at www.venturewellnessrva.com.
Okay.
There's a book now button and you can self-schedule. Generally, I ask my patients to schedule 5 days after they can get their lab work done because once you book the visit, you get all your symptom forms. So it's a long intake questionnaire. We want to make sure we've got all the information, and then you get your lab order and get those labs drawn.
And for women, do you, just to interject, do you want them to have their labs done on a certain day in their cycle?
Yeah, so ideally, if you have a regular cycle and you can time it, about 19 to 21 days around your period.
Okay.
But a lot of women are irregular. Some have had a hysterectomy but still have ovaries intact. So really, if you can get them done, when you can get them done, just kind of let me know, were you having PMS symptoms? Were you not? We can generally look at the ratio of the progesterone and estrogen and figure it out that way. Women are a little bit harder to time. So if I told everybody to get it done that day, people would never be able to get their labs done. Try to be realistic about that approach. But that way, when they get into their initial visit, we're ready to go. We've got the full panel in front of us, and we can start the plan.
Okay,
Yeah,
cool.
yeah.
All right, well, thank you, Julia.
Yeah.
Appreciate your time.
Thanks for having me, Stephanie.
Yeah, of course.
Yeah, appreciate it.
I'm Stephanie Brown, a real estate broker, mom, wife, and serial entrepreneur. Find us wherever you listen to your podcast.